So I think, yeah, 1.6 billion, it's unbelievable for a Hungarian, you know. This is just really amazing. So the topic I would like to talk to you is adenomyosis and its impact on fertility and an overview of different surgical procedures. This is the outline of my presentation. We will firstly discuss very shortly the pathophysiology of adenomyosis, its clinical relevance, the indications for surgery, preoperative workup, different techniques, outcomes, and we try to end up with some conclusions. So, as we all know, the adenomyosis is a disease with unknown origin. So we have different ideas, different hypotheses, but exactly the real cause of this disease is unknown. Therefore, the surgical therapy is not based on solid data, I would say. So, according to Charles Chaperon's paper, he has published this in Human Reproduction Update a couple of years ago. There are several ways for the pathogenesis of adenomyosis. Firstly, invasion from the endometrium. Other idea would be an invasion from outside the uterine cavity, like from a peritoneal cavity. And also there is the stem cells theory. But these hypotheses, they don't work in real world. So we don't know exactly what will cause adenomyosis. Soon Wei Go published a couple of weeks ago a very interesting article on various types of adenomyosis and endometriosis, and he claims that this disease is caused by the ectopic endometrium, which behaves like wounds, undergoing repeated tissue injury and repair. Both endometriotic and adenomyotic lesions undergo epithelial to mesenchymal and fibroblast to myofibroblast transdifferentiation and smooth muscle metaplasia. So this would ultimately lead to fibrosis. And if this is true, we see that there are so many pathways of formation of adenomyotic lesions. Therefore, we cannot even think that we are able to do a proper and definitive surgical procedure for adenomyosis. These surgeries are always deliberately incomplete procedures. So we have to take into account. So why is this important? Because it's very common. It affects a central reproductive organ. We know that majority of our patients with adenomyosis, they have severe symptoms, and it might have a negative impact on fertility and pregnancy outcomes. These are the steps for the diagnosis of adenomyosis. We start from anamnesis, and we may end up with laparoscopy or laparotomy at the end. Regarding the MUSA criteria, I think everyone is aware of the MUSA criteria system. I think it's fairly good working in the diagnosis of adenomyosis using the transvaginal sonography, and Harald will talk to you later on, because he has published very recently a very interesting article on the transvaginal assessment of adenomyosis. This is a very typical aspect of on the transvaginal sonography. You see a question mark sign on the posterior wall of the uterus. Again, we see an asymmetry in between the posterior and anterior wall of the womb. So this is the paper recently published by Harald and co-workers. It was published in the ISUOG journal, and they have found that subendometrial microcysts are very good markers for the presence of adenomyosis, and also this combination of different ultrasound markers like subendometrial microcysts, linear striation, and myometrial cysts would yield to diagnostic accuracy of, as you see here, of 85%, which is huge. The diagnostic accuracy with a good positive predictive value and negative and low negative predictive value, I think it would be a very welcome diagnostic tool. And seemingly, transvaginal sonography is the one we have to use in the first line for the diagnosis of adenomyosis. Obviously, MRI is also very reliable and it has a very good diagnostic accuracy. However, this is costly, and also the availability of MRI is different to the transvaginal sonography. We see here is a rectal nodule and very typical posterior wall adenomyosis, a diffuse adenomyosis in the uterus. We both were involved in the #NCM classification system development with Harald. It was a couple of years ago, I cannot recall. I think we have published this in 2021. And as you see here, the #NCM refers to adenomyosis. This is included here under the name of FA, and adenomyosis can be assessed by ultrasound, MRI, or surgery during the NCM classification. We have to be aware when we embark on a surgery for adenomyosis that or endometriosis, sorry, when also plan a surgery for endometriosis, we have to be aware that we may end up with persistent symptoms. And this is due to the presence of adenomyosis. So we will see later on that endometriosis and adenomyosis are very frequently coexistent morbidities. And therefore, we have to make it clear very early to our patients that after a proper surgery, they would maybe experience symptoms due to adenomyosis, even if the surgery was successful. So we have different treatment options for the treatment of adenomyosis: medical, surgical, and reproductive. Medical treatment will be covered by Harald, so I will try to focus on the surgical therapy. What can we do? We can do hysteroscopic resection, laparoscopic resection of focal adenomyosis. We can perform laparotomy for diffuse disease, mostly cytoreductive surgeries. We can administer high-intensity focused ultrasound or radio frequency ablation technology. And last but not least, we can aim for hysterectomy, which is obviously non-fertility preserving method. So if we want to preserve the fertility of our patients, we have to know why shall we do this, because actually there are no solid data on the impact on adenomyosis on fertility. This is a very recent systematic review and meta-analysis done by the group of Michel Müller from Bern, Switzerland. And as you see, the clinical pregnancy rate, the live birth rate, is very slightly higher in the control group when compared to the patients with adenomyosis. So we have no solid evidence that that adenomyosis clearly affects the pregnancy chances, the fertility of our patients. If we look at the miscarriage rate, here the data are more convincing. So adenomyosis has an impact also preterm delivery. So what we have to bear in mind that these articles, these meta-analysis and systematic reviews are based on case reports, retrospective cohort analysis, and there is 0 RCTs in adenomyosis. So there are non-prospective randomized trials. Okay, so this is again a very recent systematic review dealing with the prevalence of adenomyosis in women with subfertility. If we look at the prevalence prevalence of isolated adenomyosis diagnosed on ultrasound scan in women with subfertility, we see that this is 10%. And the prevalence of adenomyosis with coexisting endometriosis in women with subfertility is 18%, which means that this is double. So this is quite common that patients presenting for subfertility, they have both adenomyosis and endometriosis. So the prevalence is doubled. So one of the non-invasive surgical therapy would be radiofrequency thermal ablation, RFA procedure. And if we look at these diagrams, dysmenorrhea, dyschezia, dyspareunia, chronic pelvic pain, and dysuria are both significantly decreased after these procedures in 24 months of follow-up. So this seemingly working with regards of quality of life. However, as you see on this diagram, that radio frequency ablation failure is quite important, and it's at 40 months it's 10%, and at 75 months it's 13%. This would mean that all these patients after 3.5 and 6 years, they will end up with a hysterectomy. RFA, again, it's according to Michel Müller's group, is very effective in the decrease of chronic pelvic pain and dysmenorrhea among patients with adenomyosis. However, if you look at this table on the left-hand side, we see that the quality of data is fairly poor or fair. So there is very limited. And also the quality of the data, what they use for this systematic review is average. Okay, so when we compare the HIFU, the highly focused, high intensity focused ultrasound and RFA technology, we see that HIFU is much longer, takes at least an hour or 1.5 an hour, so 90 minutes in average. And RFA, it's only 30 minutes in average, so it's much quicker. However, the change in the quality of life is very similar. As you see, it's comparable. HIFU is very comparable to radiofrequency ablation, but the real difference comes when we look at the pregnancy rates, where the HIFU offers 16%, whereas the radiofrequency ablation offers a much higher pregnancy rate after these image-guided thermal ablation technologies. Pregnancy outcomes after uterus-sparing operative treatment for adenomyosis. If we see there in this review article, authors compared the excisional treatment with the non-excisional treatment, meaning adenomyomectomy, either performed via laparoscopy or laparotomy, with the non-excisional treatment, HIFU and radiofrequency ablation. And what they found with regards of live birth rate, that these techniques are very similar. As you see, it's 70% the overall live birth rate after excisional treatment, and 71% after non-excisional treatment. So they not differ a lot in terms of outcomes. Obviously, they differ in terms of something's wrong with my computer, in terms of complication rates. And also, if we look at this table, we can see that after excisional treatment of adenomyosis, most of the pregnancies were due to natural due to ART. Okay, 31% ART and only 28% of natural conception. So what is the risk of recurrence and reintervention after uterine sparing interventions? This is a very interesting meta-analysis. It has been published earlier this year in the Green Journal, and as you see here, the recurrence rate after adenomyomectomy, it's more than 12%. However, the uterine artery embolization offers a 28, almost 30% of recurrence rate. The HIFU is only 10. The reintervention rate, however, is again the lowest after adenomyomectomy, and it's comparable, the uterine artery embolization and HIFU and RFA. So as we see here, the adenomyomectomy offers the lowest recurrence and reintervention rate, which is, I mean, understandable fully, but we have to take into account the huge rate of different complications. So to conclude, we could say that low quality data shows that surgical treatment of adenomyosis has a positive effect on fertility outcome, and no unequivocal evidence is available on the impact of surgical treatment of adenomyosis on quality of life. So we have to be aware when we embark on surgery for adenomyosis that this has a very limited value at the moment. And again, it is very important to whom we offer these surgeries, because within this cohort of women, the clinical pregnancy rate is really depending on the age. As you see, it's only 3.7% after 40 years, and it's 10 times more before 39. So we have to be aware of that. So what are the major consequences or sequelae of an excisional surgical therapy for adenomyosis? We have uterine rupture after surgery during pregnancy. Therefore, we have to keep an uterine wall at least 1 centimeter. We have to take into account the presence of adhesions, both peritoneal, I mean intra-abdominal and intracavitary adhesions, and the high chance of irregular placentation. And this table shows the different techniques of excision of adenomyosis. For focal disease, we can use adenomyomectomy, either via laparoscopy or laparotomy. The U-shaped technique, overlapping flaps, or the triple flap method. For diffuse adenomyosis, we can do cytoreductive surgery, laparoscopic or via laparotomy, and transverse H-shaped incision, wedge resection, and asymmetric dissection of the uterus. So these are the most widely used procedures for the excision of adenomyosis. And lastly, I will show you a number of videos. So this is a subendometrial microcyst. As we have seen, that this is very typical and this is very common in adenomyosis, and it has a very good diagnostic accuracy. You see, we open the cyst with a hysteroscope, during the bipolar hysteroscopy, and you see the chocolate-like fluid is coming out from the cyst. And when we remove the cyst, as you will see, we can observe that there is a very little tiny remnant of the cyst here. So in a second, you see this chocolate-like fluid is still coming out. So we can either coagulate or excise this remnant of the cyst. During hysteroscopy, we can see little tiny openings within the myometrium. These are also indicating adenomyosis, and I will show you a very short video where we can observe this myometrial opening. If we decrease the pressure in the uterine cavity, we see that this is not a vessel, so there's no blood coming out. This is an opening which leads somewhere, most likely into the myometrium. So now we move to the laparoscopic surgery of a focal adenomyosis, and what we see that if we use blue dye in the uterine cavity, if we inject this blue dye, it will appear in the muscle of the uterus. So this is clearly one of the possible sources of this focal adenomyosis. Obviously, we can do laparoscopic surgery for the focal disease. We can excise these adenomyomas, but I have to admit that there is no clear cleavage plane, as you see. So they're not really able to distinguish the healthy and diseased tissue. So yeah, we can give it a try, and we try our best, but we will always do incomplete surgery when we embark on these procedures. But we have to consider this, and also we have to tell our patients that these surgeries are of very limited value and evidence. Yes, so this is how it looks like at the end. If we deal with diffuse disease, we are all aware of Osada procedure. Professor Osada was published this in 2011. This is a triple flap technique, and I will show you later on the video. So the idea is that we make a midline incision on the uterus, and we try to excise the whole junctional zone, preserving the uterine cavity. This is a sharp excision, and when this is done, we first close the endometrial cavity, then we perform the two flap, and lastly the second flap for closing the wound of the uterus. So here, this is the idea of Harald. As you will see, that we can use a blue dye in the uterus in order to make or produce a better cleavage plane, and to see how and where these little tiny openings from the myometrium will end, and if the whole junctional zone is painted in blue, then maybe we can easily cut the affected junctional zone out completely. But again, we have to bear in mind that this is just a gynecologist's mind to believe that this is like complete surgery, because by definition this cannot be. So this is what we do. We cut the affected junctional zone out, and these procedures are done by laparotomy. I think there are cases in the literature where authors claim that this is also possible by a laparoscopy, which is okay. But I think the suture of the uterus, I mean the construction of the three flaps, it's very difficult by laparoscopy. So this is the final aspect of the surgery. Finally, to conclude, in my opinion, the first line of therapy for adenomyosis is the medical therapy. And my friend Harald Krenter will talk to you later on regarding the medical therapies. There is only low and limited quality of evidence on indications of surgery. Hysteroscopy, laparoscopy, or laparotomy can be done, and there are only very limited number of case series on the surgical outcomes available. And we have always to keep in mind that there are very frightening sequelae of these procedures, such as the uterine rupture. So thank you very much. And these are the two upcoming events in endometriosis. So we have the World Congress in Edinburgh, and also there are a series of masterclass in Duisburg next month or so. Then in Bern, Switzerland, London, and in November in Hungary. So thank you very much for your attention.
Thank you, Attila. That was a wonderful and very informative talk on adenomyosis and its impact on fertility, with a very detailed overview on the surgical techniques. And sorry that we couldn't introduce Attila to our audience. He is the Associate Professor and Head of Minimally Invasive Surgical Unit, Coordinator of Endometriosis Center, and from Semmelweis University, Budapest. And he is also the member of European Endometriosis League. Thank you, Attila. That was really wonderful talk.
Thank you. If you have any questions, feel free to answer.
Yes, Attila, we will take the questions at the end of the sessions.
Okay. Okay. Thank you, Rimi.
So Harald Krentel has joined us. We would go ahead with the next topic. So before going into it, let me tell you, we are very happy to welcome you to the first webinar, which is being organized by the Endometriosis Foundation of India in collaboration with the European Endometriosis League. We thank Harald Krentel and EEL for their collaborative effort. Since April being the adenomyosis month, this webinar is dedicated to adenomyosis. So the next topic will be by Harald Krentel, and let me introduce Harald. He is the Assistant Professor of Karl von Ossietzky University, Oldenburg in Germany, and he is also the Visiting Professor of Universidad Peruana, Peru, and he is the President of European Endometriosis League. Today, he'll be discussing on adenomyosis and visa criteria with overview of medical management. Over to you, Harald Krentel.
Yeah, thank you so much for your kind introduction. And I'm really happy to join. Sorry for being late. I got stuck a bit in the OR. Yeah, I would like to congratulate you for the foundation of the Endometriosis Foundation of India. I think this is a very important step, and you already did a wonderful conference. And now EL is really happy to join forces and to do these activities together. I think this is a wonderful possibility that we all have, and that's why I'm extremely happy to join you today. My topic is the diagnosis of adenomyosis, and I will try to give you a short overview on this very important disease. So this is a snapshot from our office job, and this is a patient she just came along with a symptomatic pelvic pain, bleeding disorders, a 35-year-old patient, and she told me that in her history she had laparoscopic surgery for endometriosis, and she's looking for a pregnancy, but so far she was never successful of having a baby, although she underwent 8 times assisted reproduction. So I think this is a quite hard story to tell. And then we did the ultrasound, and the TVS just revealed this image. So this is something that in 1 minute, you know that the problem of this patient is adenomyosis. And that's why adenomyosis is so important, because there is a certain impact. And when we deal with patients with endometriosis, we should always have adenomyosis at least on our mind and think about it and try to involve it in our diagnostic process and therapeutical process. So there might be a higher incidence than we believe, because we have difficulties to diagnose adenomyosis. I'm quite sure that in many cases, we just do not notice that there is adenomyosis. And then, of course, it's important because it's the central reproductive organ. And most of the patients with adenomyosis have some symptoms. And when we have patients with a deep endometriosis, they do not only have symptoms because of their endometriosis, but also because of adenomyosis. The disease has a negative impact on fertility, with reduced pregnancy rates and reduced birth rates and higher abortion rates. And there's a clear relation to several obstetrical problems like premature birth, premature rupture of membranes, uterine rupture during labor, and maybe also to the postpartum hemorrhage. So there might be a bigger relation to adenomyosis than we think. Another key point is that it's a disease across all the lifespan of our patients. So this goes from adolescence to the post-menopausal time of a life of a woman. And it can start with dysmenorrhea and bleeding disorders, and it just can also make problems in teenagers, but also in patients with 45 years. And of course, in between, when women want to become pregnant, this can be an issue. And the incidence, as I told you, or prevalence is not clear, because the data that we have comes from hysterectomy cohorts. And of course, it's not possible to take a group of women from 18 to 30 and take the uterus and check whether there is adenomyosis or not. So we don't have this information in the younger patients. But when we take the hysterectomy cohorts, we have a prevalence of more than 40% in just a normal group of hysterectomies. And when we look for the patients with the indication bleeding disorder or dysmenorrhea, then we have a rate of almost 60% of adenomyosis cases in this group. So this is quite a lot, and it makes me think that younger patients must also have these problems. So when we diagnose and when we are in process of diagnosing the disease, we have to consider adenomyosis. And then, of course, patients can tell us about her symptoms like a central pelvic pain, maybe a brownish spotting, which comes from these cysts that Professor Boko just showed you. And then during gynecological examination, we can get some clues. And when we do then 2D or 3D transvaginal ultrasound, we can be very sure, you will see, of our diagnosis of adenomyosis. And if it's necessary, we can add MRI. So what we usually find is a painful uterus. And sometimes even during examination, the uterus can be painful. And patients report dysmenorrhea, dyspareunia, and bleeding disorders. The uterine size can be different. The uterus can be enlarged, but be careful, because it's not always a big uterus. It can also be a small normal size uterus without any asymmetry, still having adenomyosis. The uterine mobility can be different maybe, especially then when there's also a deep endometriosis related. And if there is a deep endo, the chance to also have adenomyosis is around 50%. So the current data shows very clearly that ultrasound by transvaginal approach is the first line diagnostic tool. And the MRI would be as good as ultrasound, but it's more expensive and not that available. And when you want to see how you can detect adenomyosis, you can go through this nice open access paper, which is from 2018. And these are the MUSA criteria. They show you which kind of signs you can see during transvaginal ultrasound. And there are several signs, as you can see here. And some of these signs are more important than others. And the problem is that we still don't know exactly which are the important signs, and is one sign enough, or should we have 2 or 3 signs? So this is not clear. But the Musa group, so this group of international colleagues, they did a revision of their initial paper in 2022, and in that revision, they divided the signs into direct signs and indirect signs. And the direct signs are myometrial cysts, hyperechogenic islands in the myometrium, and subendometrial lines and buds. This is how the Musa group calls these findings. And if you see these direct signs, then it's quite clear that you talk about adenomyosis. And on the other hand, you have indirect signs, for example, asymmetry or globular enlargement, and these are not that relevant because they can be part of an adenomyotic uteri, but the criteria are not that clear. So it also might be another reason for a globular enlargement or asymmetry, thickening of the wall. We recently published a multi-center study from Germany and Austria, and this study shows something similar to the Musa criteria. So what we found is that the most accurate diagnostic sign in detecting adenomyosis are the subendometrial microcysts. I will later show you how they look like. And when you see subendometrial microcysts without any other sign of adenomyosis, you can be very sure that this is adenomyosis. If you find subendometrial microcysts, and additionally, you have another sign like myometrial cysts or linear striation, then you almost reach a prediction of 100%. So then you are very close to a good prediction. On the other hand, we have had a lot of false positive and false negative results, and these were mainly uterus with something like heterogeneous myometrium or uterine enlargement or asymmetry. Signs that are not that clear and they are not so accurate. So, for example, when you have additional fibrates in a uterus, then this uterus will be enlarged. This uterus will be asymmetric. And this means that then you might think there is adenomyosis, but you're on the wrong way. And then you overdiagnose the disease. So this is quite a problem. And I mean, I do this ultrasound a lot. I do ultrasound in all the patients I do surgery on by myself. And I still have a lot of problems diagnosing adenomyosis, although we have this paper. So it's really difficult. But if you see these little cystic lesions like this one, with a white lining, with a hyperechoic lining, then you can be very, very sure. And this is also, it's the same. I would say these hyperechoic spots are also cysts, but evacuated. There's no content inside. That's why you just see the white spot. But from time to time, this will fill up again with a bit of brownish liquid, and then you have a small cyst again. These cysts are 2 or 3 millimeters. Look at this uterus. It's a beautiful uterus. Here's the small cystic lesion. So here's the bladder. This is the anterior wall, wonderful endometrium, a normal posterior wall. The uterus looks quite normal, really nice. Here's a small cystic lesion with a small hyperechoic ring. This is adenomyosis. Here's another example. Here's the ring, you see? This is a small cystic lesion, brownish content, hyperechoic lining. When we published this article, I had the discussion with the reviewers if the hyperechoic lining of the microcyst is endometrium or fibrotic tissue. So I don't know. I'm still not sure, but I think we agreed on endometrium, which makes sense. But that was funny in a way. So here we are seeing the same thing, a small cystic lesion in the subendometrial tissue. And yeah, this is really interesting. And sometimes you need to take some time. Here's another case. So here you see several of those cysts, you see? A lot of these cysts. So this is a completely irregular junctional zone. There are a lot of cysts. The uterus is asymmetric. It's a heterogeneous posterior wall. So this is adenomyosis, but 100%. And if you want to be sure that the cyst is not a vessel, you can use your Doppler and then you will see that there's no flow, like in this case. And again, this is 2.5, 2.6 millimeters. And again, here you can see the hyperechoic lining. So it's just the need to really scan for these changes during your examination. These are 4 images. It's the same uterus. Here you can see a larger cyst, which is really bigger now. It's almost 5 millimeters. You can see the small spots here in the junctional zone. You can see there's no flow and it's just irregular, but the uterus is not enlarged. It's not asymmetric, but still this is adenomyosis. If you take care of the junctional zone, the findings in ultrasound and MRI are different. This is just important to know. So when you do your ultrasound and additionally you ask for an MRI, and you have different results, this is normal because the technique is different. So it shows you actually the same, but the reporting is a bit different. So just be careful that there are discrepancies, but this is okay. This is how the tissue looks like. It's a fragment from a uterus, from a hysterectomy. And we just resected the subendometrial part. This is the endometrial lining. And here you can see this small bubble, and when you open it, there's the brownish content inside. And this is what we see during ultrasound. So here's another example. And maybe if you scan your patients after this talk, or you already knew that, then you will easily see the small cystic lesions. It's really easy to see. And then, of course, we have different signs, like in this uterus, you can see the asymmetry. You can see that the anterior wall is completely changed. It's a diffuse adenomyosis of the anterior wall. There are cystic lesions. There are hyperechoic islands. There is the linear striation, which is also a very important sign. Here you can see a lot of cystic lesions, a lot of hyperechoic spots. Here you can see the lines. Here's asymmetry. Here you can see the question mark sign, which is related to the tissue plus in the posterior wall. The question mark sign can also be related to the fixation of the uterus due to deep endometriosis to the posterior part, but it's not always the reason. In some cases, there's no fixation by deep endo, and it's just a question mark sign because of the asymmetry of the uterine walls. You know? So yeah, we just have to include the uterus to what we do when we examine our patients, especially when we talk about pain management and treatment, and when we talk about fertility treatment. In this case, I was not sure. You see, there's a slight question mark sign. There's a thickening of the posterior wall. It's a bit heterogeneous, but I couldn't see any cystic lesions. But in this patient, we did a biopsy with a small bipolar loop, and the biopsy was positive for adenomyosis. Yeah, but I was not sure, of course. If you have a 3D ultrasound, this is a nice tool, and you can use it because then it's maybe easier, even easier to see all these small changes by using the coronal section of the 3D image. I think this is really important too, but unfortunately, we do not all have access to a 3D machine. Yeah. And maybe one last thing regarding ultrasound, if you scan the uterus, of course, there are a lot of uteri which are not just containing adenomyosis as a disease, but also myomatosis. So in many patients, we have uterine fibroids and adenomyosis, and this is okay, but it would be good to know both diseases before you start doing your procedures. So in this case, you have a peripheral Doppler, which is typical for fibroids. And here you can see that there's a central vascularization, and it almost looks like something malignant, but this is typical for adenomyosis. This is important to distinguish both diseases. Then, as Professor Boko just showed us, we can have these signs in hysteroscopy, and I just wanted to add this because I just recently did this video, and this is so interesting to see that all the subendometrial tissue is changed in that area of the fundus of the uterus. And of course, this must have a huge impact on the fertility of the patient, because this endometrial layer is full of well, let's say toxic tissue for the ovula. So if we know that there is adenomyosis, what can we do? First of all, we have to think, okay, what is the plan? What is the plan of endometriosis, deep endometriosis, fallopian tubes, ovaries, and uterus? And then we have to find the right way about medical treatment, surgical treatment, or reproductive treatment. And the factors are symptoms. Is the uterus part of the problem? Then we should include the uterus to the treatment. Is there a family planning ongoing? Then, of course, it's important to also take care of that. If we just want to treat adenomyosis, we have to also take care of the deep endometriosis. So sometimes, for example, I see hysterectomies done for adenomyosis, but the surgeon just left all the deep endo behind. So, of course, these patients will continue to have problems. And then, of course, age is an important factor, as we just learned by Professor Boko's presentation. Data shows two things. One thing is that data shows that treatment of adenomyosis has a positive effect on symptoms. This is clear. And the other thing that data shows is that there's also a positive effect on fertility outcome. But it is absolutely not clear which is the right way to go. So should these patients just go to repro, or should they get a pre-treatment with GnRH analogs and then go to repro, or should they have surgery and then repro, or combined with medical treatment? So this is not clear. We have no clear data on that. So there is no recommendation today, and we have to individualize the approach and find the perfect and best way for every patient, depending on the factors that I just showed you. What we know is that treatment reduces dysmenorrhea, and this applies for medical and also surgical treatment. And we also know that treatment reduces bleeding disorders, and this is even measurable by CH12-5. And there might be a good effect on fertility outcome, but we don't know exactly if this also applies to surgical treatment, and then which technique. So what we need is a clear classification of the disease, and then we need randomized trials to really find out about all these questions. If we want to treat adenomyosis by medical options, you can just use whatever is good in endometriosis also works in adenomyosis, and whatever is reducing estrogen levels works in adenomyosis. So the most common medical options are those that you can see here on this slide. And one of the most important is the LNG IUD. And then, of course, there's a place for GnRH analogs and recently also for GnRH antagonists. But also you can try to use oral contraceptives or gestagenes like Dionagest. The LNG IUDs are quite useful, especially in patients when they already have had their babies and they don't want to get more babies, and but they refuse a hysterectomy. So then you can try to use a Mirena, and this could really help to improve the situation. This is also an option in young patients when you detect adenomyosis, for example, in a 22-year-old patient, and she wishes to become pregnant in the future, maybe in 8 years. And we should do something in that time to protect the uterus. So maybe the LNG IUDs also could play a role there. But the problem is that when you insert a large LNG IUD, like Mirena, for example, then there might be problems just due to the fact that the IUD is too big. And if you use the smaller one, for instance, in Germany, it's like that, then the dose is lower, and then maybe the effect is not good enough. So this is quite a problem, and we don't know. We need to find out. Then after surgery, an LNG IUD can also be helpful, because anyway, when you do a surgery on adenomyosis and patients then want to become pregnant, it's good when they have a reduction of the hormonal activity, which could be done by Dionagest, LNG IUD, or GnRH analogs until they can become pregnant after the wound healing of the uterus. Dionagest is also helpful as it is able to reduce symptoms, but unfortunately, in adenomyosis, it causes bleeding. And many patients taking Dionagest start to have an adverse reaction in terms of menorrhagia. And this is a big problem because these patients then discontinue the treatment because, yes, it reduces the pain, but the bleeding problem is even worse. So this is not a very convincing treatment approach, in my opinion. Let's talk about GnRH analogs. You can use this as a pre-treatment before you want to resect a large diffuse adenomyosis. In fibroids, we don't do this because we are afraid to lose the plane in surgery, but in adenomyosis, there is no plane, so it just will be a bit smaller and maybe bleed less. So I think this is a good treatment. And of course, as I just explained, you can use this in the post-operative wound healing time, like 3 to 6 months. When a patient wants to become pregnant after such a surgery, this would be an optimal pre-treatment. But I recommend to always do this just in exchange with a specialist for reproduction. So when we do plan these patients for surgery or for medical treatment and they want to become pregnant in the future, we always ask our reproductive specialists for their opinions and then try to find the best solution together. The antagonists, the new ones, the relugolix treatment in combination with gestagenes and low-dose estrogen is not yet on the market in Germany for adenomyosis and endometriosis. I don't know how it is in India, but here it will come. And then we will see if it works. Yeah, it's on the market for fibroid treatment, and we just have to find out. But I know that many people are just using it off-label now, and it seems to be quite good in dealing with adenomyosis-related symptoms. And of course, the reproductive specialists still use GnRH treatment as a long cycle protocol in patients with adenomyosis. I know that in endometriosis, especially deep endometriosis, this is not the case any longer, but I think there is a place for this pre-treatment in patients with adenomyosis. The main question for me is, if we now start to become better in diagnosing adenomyosis early, what will be the benefit? Will this help us not just to recognize the disease, but also to protect the uterus from worsening during years? And this is the main issue. We have to find solutions for the very young patients with adenomyosis, first in treatment of their symptoms, but second, in how to protect the uterus from having problems in later years in becoming pregnant then. So to summarize, adenomyosis can be diagnosed by combining symptoms, examination, and TVS. We can differentiate these signs of ultrasound in direct and indirect signs, and we should avoid false negative, but also false positive diagnosis, which is not that easy, and then of course include the disease to our treatment concept. And what we clearly need, not just in adenomyosis, but also in deep endo, are ultrasound workshops. And with this, I would like to end, and it's a pleasure for me to invite you to the 7th European Endometriosis Congress in Bucharest next year. Thank you so much.
Thank you, Dr. Herald, for your wonderful and detailed talk. And it was really good to know about all the highlights you have put on for the ultrasound to help in diagnosis and the management.
Thank you so much.
Now we have Dr. Vimi Bindra with us. She is a consultant and SRC accredited master endometriotic surgeon at Apollo Hospitals, Hyderabad, and she's the founder of the Endometriosis Foundation of India. Over to you, Dr. Vimi Bindra.
You can see my screen?
Yes.
Yeah, thank you, Dr. Harald. That was a wonderful talk. And the same question even I'm going to ask what you said, like, will early diagnosis halt the progression of the disease? So I'll take all of you through the spectrum of adenomyosis. And the last question, the last slide is the same as you said, that what will happen if we diagnose them early? Will we be able to protect the uterus, or we will be able to stop the progression of the disease? I have nothing to disclose and no conflicts of interest. Adenomyosis is a benign gynecologic condition and is classified into diffuse or focal adenomyosis depending on the extent and location of disease, as well as the histological classification. Surgical treatment is always a subject of debate and sometimes conflicts as well. It causes significant symptoms: dysmenorrhea, chronic pelvic pain, dyspareunia, menorrhagia, and infertility, with adverse fertility and pregnancy outcomes. We all know that adenomyosis is no longer a histopathological entity, and it's a clinical condition which can be diagnosed by clinical suspicion and imaging without surgical intervention. Dr. Harald has beautifully shown that how we can pick up adenomyosis at very early stages as well. So our intention should be to correlate the symptoms. As he also said that uterus may be absolutely normal, there may not be any asymmetry, but adenomyosis can be there. I'll be showing a similar case at the end of my presentation. So the spectrum I'm talking about is how we look at it, like we find isolated junction zone abnormality, adenomyosis and its variant, the inside-out pattern, the centrifugal growth, adenomyosis coexisting with deep infiltrating endometriosis, focal adenomyosis of outer myometrium, focal adenomyosis of outer myometrium with DIE, JCA, ACUM, and the atypical adenomyosis. Now, junctional zone abnormality, it is often a missed entity. The diagnosis is delayed because Can you please mute yourself? So junction zone abnormality is a major this thing which is often diagnosed late if the imaging is not done properly. Diffuse adenomyosis or focal adenomyosis, adenomyosis with DIE, foam, JCA, and atypical adenomyosis. A thickened junction zone is defined as a precursor to adenomyosis. A serrated junction zone seems to correlate to image-based changes in the junction zone and inner myometrium. Evaluation by 3D transvaginal ultrasound and MRI detection of junction zone changes specify the location and correlate to histopathology. These junction zone patients, whenever we have done a hysteroscopy, there was a claw-like appearance at the fundus, and this was typical to junction zone changes in patients, especially with the isolated ones. And whenever there was a laparoscopy done for these patients for indicated laparoscopy, there was peritoneal endometriosis as well. The most frequent finding to diagnose adenomyosis is thickening of junction zone, and several criteria have been proposed. Junction zone of at least 8 to 12 millimeter, the maximum junction zone by total myometrium ratio of over 40%, and a difference between the maximum and minimum thickness of greater than 5 millimeter. However, a thickness exceeding 12 millimeters seems to be highly predictive of adenomyosis. A common pitfall to diagnose junction zone abnormality is caused by transient uterine contractions that can mimic either T2 weighted hypointense bands perpendicular to the junction zone or focal thickening of the junction zone. In those cases, the repetition of MRI acquisition may help to differentiate a physiological condition from adenomyosis. Now, all the literature says that a junction zone of less than 8 millimeter generally allows clinicians to exclude the presence of adenomyosis, whereas a measurement between 8 to 12 millimeter identifies a condition if other criteria are present. But in our practice, very frequently we have seen a junction zone of less than 8 millimeter, but the junctional zone is abnormal. So is the measurement important or the morphology is more important for the junctional zone? We need to find out. Disruption of junctional zone. Just one minute. So disruption of junction zone endometrious continuity provokes adenomyosis, a condition that causes chronic inflammation and fibrosis. It negatively affects the normal function of junction zone. The imaging by magnetic resonance imaging or MRI and 3D sonography can diagnose junction zone abnormality. Now, these patients have disproportionate dysmenorrhea. The patient presentation, usually these are young patients, age group 25 to 35 years, typical history of dysmenorrhea, out of proportion dysmenorrhea, they complain. Usually they do not present with menorrhagia. They have already used multiple medical treatments and invariably the imaging was negative. But as we are a referral center, when we looked at their junctional zone, it was highly abnormal and they do not fit into the criteria of 8 millimeter always. So will all these patients develop adenomyosis is our question. What is the best treatment modality for them? Will hysteroscopic resection help if they are not trying for conception or family is complete? And junction zone thickening or junction zone abnormality, which is more important? So all the literature which we have searched mentions about the thickening. Abnormality is one of the features, but without thickening, abnormal junctional zone also presents with severe dysmenorrhea, with severe VAS scores and bad quality of life. Adenomyosis and its variants, this is the most common clinical issue which all of us face, the focal adenomyosis, diffuse adenomyosis. Dr. Attila and Dr. Harald they have already beautifully covered this topic. In this hysteroscopy, we always find some of the features of adenomyosis because this patient had a posterior focal adenomyoma. So you can see the punctate hemorrhages and other signs of adenomyosis on the posterior wall. And focal adenomyoma are much easier and much simpler to treat as compared to diffuse adenomyosis. So double flap technique, triple flap technique, with overlapping technique, different techniques, different surgeons. It all depends on the surgeon's experience and their skill. And laparoscopy or robotic surgery, done in a minimally invasive way, is always a challenge. But then if you have mastered the suturing skills, it is not as difficult as diffuse adenomyosis. So the only principles we have to maintain is that we should maintain a 1 centimeter to 0.5 to 1 centimeter from the serosa, and then 0.5 to 1 centimeter from the endometrium as well. So this was done as a triple flap technique. And as Dr. Attila was showing, that injection of the methylene blue. So various methods surgeons use. Sometimes they put a manipulator in the uterine cavity and they can feel it and assess the margins. Sometimes you might open up the endometrial cavity and then decided, like here, the endometrial cavity was just open at the tip and you have to be at least 1 centimeter or 0.5 centimeter away from the endometrium when excising these focal adenomyomas. And then with the overlapping technique, with the double layer suturing, it has to be done. As Dr. Attila already said, that there is no randomized trial for the outcomes for these patients. It is very difficult to say that which technique is better and which has better reproductive and surgical outcomes. Now, coming to diffuse adenomyosis, it is always controversial. Such huge diffuse adenomyosis where the uterus has already enlarged to 18 to 20 weeks, this uterine volume was almost 504 cc. Patient had tried everything, multiple IVF failures, but when nothing works, they want to preserve the uterus. So this is an attempt to save their uterus, but then we are unsure about the reproductive outcomes in such patients. So we need multi-center prospective studies where we can prove the outcomes for such patients. Laparotomy technique, USADA technique was quite popular, but minimally invasive technique by robotic or laparoscopy with good suturing skills can also be attempted. In this, we did a double flap technique. In diffuse adenomyosis, it is very difficult to find out the margins, the junctional zone, and very difficult to, it is basically a cytoreductive surgery, as Dr. Attila said, and it is not exactly an adenomyomectomy, because completely we cannot remove everything. So again, here the basic principles work, that you have to be away 0.5 to 1 centimeter from the serosa and also from the endometrium. So this was a robotic surgery with which debulking surgery was done, a cytoreductive with a double flap technique. And patient had very good pain relief, VAS scores improved drastically, and she is waiting for her IVF procedure. So whenever we counsel such patients, it is very important that we tell them about the rupture risk, and the outcomes of adenomyomectomy are still not proven as per the literature, and there are no randomized trials to prove that one procedure is superior over the other. So overlap technique always gives a better strength, because here the residual myometrial thickness is very, very important, because if the suturing is not good, it may have higher rupture rate, higher chances of pregnancy complications. But they also find a significant improvement in their visual analog scores post this surgery. They may not have a complete relief because it is not possible to completely remove adenomyosis, but then they report a significant reduction in their symptoms. Now, this is another case where the uterine volume was 405 cc, and we had done a cytoreductive adenomyomectomy, where the residual, after 3 months, you can see a beautiful endometrial lining, and the residual adenomyosis was only 27 cc as compared to 230 cc before the surgery. And patient is absolutely painless, and she's also waiting for her reproductive treatment. Adenomyomectomy is surgically challenging because of the obscure boundaries between the normal myometrium and the adenomyotic lesion, intraoperative blood loss, and technical difficulty with suturing tissue planes to eliminate the dead space at the operation site. Indications all of us know: severe dysmenorrhea, hypermenorrhea, not responding to medical treatment, infertility and recurrent miscarriage, desire to preserve fertility or the uterus. Factors related to uterine rupture, adenomyosis removal method, either we are using electrocautery or cold knife method, degree of extirpation of the adenomyosis, extent and size of the uterine muscle defect, method of reconstructing the uterine cavity and the uterine wall, postoperative wound infection and postoperative hematoma formation, the period of contraception prior to postoperative pregnancy, and the skill of the surgeon. This was a comparative study between the robotic and laparoscopic assisted adenomyomectomy. Surgical outcomes of robotic adenomyomectomy were comparable to those of a laparoscopic approach as per this study, but we also need, again, multi-center prospective studies using standardized surgical procedures, because still the adenomyomectomy procedures, other than OSADA techniques in a minimally invasive way, there is no standard techniques. Various techniques are being used, the double flap, triple flap, edge technique, or wedge resection. So there has to be a standardized technique used by all the centers, and then we need to study it on a long-term prospective basis. Now, as Dr. Attila was mentioning about the conservative options of radiofrequency and microwave ablation, we are not using radiofrequency, but we have started using microwave ablation where patient is not willing for adenomyomectomy, or she wants to preserve her uterus, or it is done for fertility. Again, we need a long-term study where we need to follow up these patients for reduction. In 6 to 9 months, they show a significant reduction of the adenomyotic volume, but as it is a progressive disease, the residual tissue, because it cannot be ablated 100%, we ablate around 60 to 70% of the adenomyotic tissue. So there will be some progressive growth. So we need to compare that over a long term to find the results of such procedures. This was a recent study published in 2022 where they have shown that ultrasound-guided microwave ablation has proven to be an effective, minimally invasive alternative treatment for symptomatic adenomyosis, and an increased number of patients have been benefited. However, a significant difference in symptom relief and incidence of post-ablation complication has been observed in previous studies because, again, it was not standardized. The criteria with which the patient selection was done was not standard. This spectrum presents in young patient, reproductive age group, and perimenopausal age group. Patients desirous of hysterectomy in the perimenopausal age group is not a challenge. The challenge is the younger age group and patients desirous of fertility. Future research questions are adenomyomectomy and its results on quality of life and reproductive outcomes as prospective multicenter study, and results of minimally invasive surgery for adenomyosis, robotic and laparoscopic approach. Coming to focal adenomyosis of outer myometrium, which is an outside-in pattern of growth as compared to the inside-out pattern for focal and diffuse adenomyosis, transvaginal ultrasound shows a question mark sign, which signifies a fixed uterus with fundus adhered posteriorly to the rectum and our sigmoid colon. MRI image shows outside-in pattern of myometrial involvement with relative sparing of junction zone. So the first spectrum, what you saw was the complete involvement of the junction zone, and this is something which does not involve the inner myometrium and the junction zone. It only involves the serosa and the outer myometrium. So in DIE, many of the patients, we started finding this foam and we started excising it as well. And we found that it was quite away from the junctional zone. It was much easier to remove, much easier to suture as compared to the diffuse adenomyosis and other types of adenomyosis. This was a patient where she had junctional zone abnormality as well as posterior foam and anterior foam. So these are little challenging cases, like how to manage them, when to schedule them for surgery, because all kinds of medical management had failed for them, then only we take them for surgery. So we had a study group over 1.5 years where we had 30 patients of focal adenomyosis of outer myometrium, where we had excised it along with deep infiltrating endometriosis excision. So this study group involved patients, and we had excluded patients who underwent hysterectomy for focal adenomyosis of outer myometrium. So the uterine preserving surgeries were done for these 30 patients. The mean age of onset of symptoms was 30.4 years, and 80% of patients had regular cycles, of which 73.3% had normal flow during periods. Patients mainly presented with symptoms of dysmenorrhea, seen in all of them with an average pain score of 6.3 on a scale of 10. 46.2% were trying for pregnancy, 29.7% had primary infertility, and 16.5% had secondary infertility. Our main diagnostic tool for clinically suspected patients was ultrasound, which picked up the lesions in 79.2% of the cases, and MRI was needed in only 6.6%, and both imaging modalities were used in 13.2% cases, because in some cases when ultrasound, we needed a characterization by MRI, so we had to use the combined modality for them. On follow-up of all these patients for a period of 6 months, there was significant reduction in VAS scores. 46.2% of women who were trying for pregnancy, 9.4% of them conceived. One patient had recurrence of symptoms in 6 months, but no lesion recurrence. Now, the question is these patients, we did not find any literature where foam excision was done. There was only a paper in Fertility Sterility where they had compared the symptom profile of patients where foam was present and foam was not present. Thickness of the junction zone is an important factor for the heavy menstrual flow, and as our patients had foam which does not involve the junction zone, they did not have complaints of heavy menstrual flow, and 80% of the patients had regular menstrual cycles. So this differentiates from other kinds of adenomyosis. These patients are young patients, reproductive age group, 20 to 40 years, typical history of progressive dysmenorrhea, painful defecation, because most of these patients have rectal involvement and rectal tethering is noted, infertility, and if infertility, multiple failed attempts at assisted conception and IVF failures too. So what are the future research questions? Foam is a phenotype of adenomyosis, or should it be regrouped? It should be excised with DIE or left alone, and we need a comparative study to answer this and long-term outcomes of foam excision. Now, this is a separate entity which does not involve the junction zone. It does not involve the complete myometrium. It is separate, but often the diagnosis is delayed because of the atypical appearance and failure to diagnose on imaging. These usually are present as thick walled cystic myometrial lesion measuring along the left or right anterior upper uterine body covered by uterine serosa in the peripheral third in MR images. And these are basically reported as subserous fibroids on imaging, but if a MRI done or a 3D is done, you can always see the blood signals on MRI and it can be picked up. As anamnesis is the most important thing, listening to the patient. If she complains of one-sided pain, persistent pain, progressive chronic pelvic pain, definitely it could be an ultrasound reporting of a subserous fibroid. Always have a suspicion that it could be JCA. Look for something and we will find it. So JCA excision is the very easy and it is a complete excision. Recurrence rates are very less and quality of life improves instantly, and usually because their other myometrium is absolutely normal. So these were patients in last 1 year where we had JCA, 5 patients had JCA and all of them were less than 30 years old, and they are often diagnosed as, one of the patients was diagnosed as even ectopic and others were diagnosed as subserous fibroids. These are young patients, age group 20 to 30 years, typical history of dysmenorrhea. They have severe pain, VAS scores of 10/10 as junction zone abnormality patients, and they may complain of one-sided pain. They have localized pain. If the lesion is on the left side, they complain more of left-sided pain. They do not present with menorrhagia, multiple medication, but none of the medicines work for them, and previous imaging showing a subserous fibroid. So you should get a suspicion of JCA or ACUM in such patients. Now, developing a protocol to detect these patients with JCA at the earliest will be the only answer to such clinical scenarios where we can excise this lesion completely and give them a good quality of life. Now, as this is a case of atypical adenomyosis and junction zone abnormality, you can also see here the claw-like appearance at the fundus, which I mentioned about the junction zone abnormality. This patient had pain, left-sided pain only for last 7 years. The first pregnancy she conceived with IVF, and 4 months back, she had undergone a robotic surgery in UK and they had removed some peritoneal endometriosis. Then she presented to us with severe pain. None of the medications were working for her. And then on imaging, we found an abnormal area in the myometrium on the left side. And then we wanted the characterization. We got an MRI done. And in the MRI, if you can see, there is a junction zone abnormality. along with an abnormal adenomyotic tissue. And we also scheduled her for robotic surgery. And if you look at the first look of the uterus, it looks absolutely normal. There is no asymmetry, no abnormality. So it was missed, and patient had severe pain for last 7 years. So we scheduled her for adenomyomectomy, and they had also inserted Mirena for her, which did not work. So the adenomyomectomy was done because we knew the exact location where the adenomyotic tissue was there, and it was near to the lower segment and near the isthmus. The complete adenomyomectomy was done, and it's like 8 weeks post-operatively, patient is absolutely pain-free. And histopathological diagnosis confirmed adenomyosis. So here you can see we had put a manipulator here, and we sutured the uterus in 2 layers and reconstructed the uterus. As it was at an abnormal location, usually these locations are not very common for focal adenomyosis as well. They are either anterior or posterior. But this was associated with junction zone abnormality and an abnormal location of adenomyotic tissue, which was difficult to pick up. But then when patient says there is a pain, we need to find it out. So what is the take-home message from this? Providing precise anatomical information about the uterus with respect to zonal anatomy in correlation with clinical symptoms gives clue for early diagnosis. Morphology over morphometry analysis of junction zone will aid in early pickup. So look and not measure. This is what we wanted to highlight in the today's talk, was the junction zone abnormality, which is often overlooked. And if we depend only on the measurements, then we might miss many of these cases who have severe pain and not responding to any of the medical management. A minimally invasive approach to fertility sparing management of diffuse adenomyosis is safe and feasible with good anatomical results. Patients should be advised on the risk of uterine rupture during pregnancy, after adenomyomectomy, before the procedure. Multicenter prospective studies using standardized surgical procedures are needed to confirm the effectiveness of adenomyomectomy. So future research areas should be highlighted on isolated junction zone abnormality targeted treatment, and can detecting junction zone abnormality prevent development of early diffuse or diffuse adenomyosis? Massive diffuse adenomyosis in teenagers and younger population, what causes such rapid growth of adenomyotic tissue, and what is the ideal treatment for them apart from hysterectomy? These are the 2 questions which Harald also addressed, and I also wanted to discuss you, because this tackles us every day in the clinical scenarios when patients present to us. Thank you.
Thank you, Dr. Vimibindra, for that wonderful explanation of the various phenotypes of the adenomyosis and the importance of knowing the junctional zone abnormalities and their impacts which will have an impact on the quality of life on the woman suffering from it.
Can we take the questions now? I think there was a question for Attila, that what is the literature supporting the removal of subendometrial cyst? Dr. Attila, are you
There's
there?
none. Obviously, there is no evidence on that. So the problem with endometrial surgery, I mean, the surgical treatment of adenomyosis, there is very limited evidence. There are only retrospective data and poor quality of case series. So this is what we have at the moment. We urgently need good quality prospective randomized trials.
So my question to you is, those who are not desirous of pregnancy and the family is complete, the junctional zone abnormality, can it be treated hysteroscopically?
I think there's no way. I mean, the best is to administer levonorgestrel IUD in these cases.
Yeah, so all these cases responded very well to LNG-IUS. But the last case which I had shown, she had LNG-IUS as well, but she did not respond. because there was associated atypical adenomyosis along with the junctional zone, so we had to resect it.
Okay, so what would be the age of this patient?
She was 29 years old.
1999. Okay, then it's bad luck. Maybe we could go for oral GnRH antagonist with add-back therapy. The value is 40 milligrams per day.
She had taken 6 doses of GnRH, Dynogest, oral contraceptive pill, every possible medication in last 7 years she had tried. And she underwent a surgery 4 months back in UK for peritoneal endometriosis excision. But then when she came to us, we could pick up that abnormal area and we excised it.
Okay, and how is she now doing?
Absolutely fine. 0 scores.
Really? That's
Really.
cool. Congratulations. It's very nice.
Thank you. Thank you. We have some more questions. Dr. Neena Gupta is asking treatment in young adolescent patient.
Okay. In case of the diagnosed adenomyosis in adolescents, I would firstly offer the IUD from the JADIS IUD, which is smaller in size, contains also levonorgestrel, and I think this would be the best option. Secondly, I would go for progestin-only pills for at least 6 months, and we'll see the effectiveness of the medical therapy.
Shweta, can you take the questions?
Yes. And there's another question which says that is it difficult to diagnose in adolescents as a transvaginal scan may not be possible? So would a transabdominal scan would give a similar picture? Will it help us in diagnosing?
Unfortunately not. The best option in these patients would be the MRI, the pelvic MRI.
Yeah. And Dr. Atilu, there's another question which says regarding the medical management. So what is the routine use of GnRH agonist treatment before Mirena to reduce the bleeding disorders, which can happen in the first months when the Mirena is inserted?
Okay, sorry, can you repeat the question, because I'm afraid I didn't get it. So before Mirena, GnRH.
He used GnRH agonist. This is to reduce the bleeding, which can happen when Mirena is inserted in the first few months.
I wouldn't. Me personally, I don't use it, and I wouldn't recommend it.
And what do you think about the use of letrozole as medical treatment for adenomyosis, Dr. Raji?
Letrozole, you mean?
Yes, yes.
Okay, I think it's not the best option. For me, the first-line medical therapy is LNG IUD for adenomyosis. Secondly, Dynogest, only 2 milligrams a day, or progestin-only pills. This would be my first treatments of choice.
And Dr. Vimibindra, there's another question which says about a 22-year-old female who is pregnant at 24 weeks with 3 prior abortions with a history of adenomyosis, which was diagnosed before conception, and she's presenting with pelvic pain. So how do we manage such a patient?
Okay, maybe Vimi, you can answer that, because you're.
No, in this they have not mentioned was there a previous history of adenomyomectomy or not. So she was only diagnosed with adenomyosis. I think any conservative management will be good enough. She's 24 weeks pregnant. So we just have to give her conservative management with simple analgesics and then see the progress. If she was operated previously, then we have to look for the scar thickness and myometrial thickness, and if there are any chances of rupture as well. Pranavi is asking imaging phenotypes of adenomyosis. I think we have discussed that in detail in the MUSA
Yes, we
criteria.
did.
And in my talk also, there was all the imaging phenotypes only. That is what the spectrum we were talking about.
And Dr. Vimibindra, there's another question which asks about the junctional zone abnormality. Look, do not measure. I'm not sure about that, but is imaging.
I had mentioned that look, do not measure. Look means look for the morphological features rather than the measurements. So it's more morphology rather than the morphometric. That's what I mentioned. So that is, they have written. So imaging patterns suggest progress to reflux menstruation with concomitant DI or progresses to intrinsic diffuse adenomyosis with anterior posterior wall involvement. How do we confirm in young patients and follow-up cases of junction zone abnormality diagnosed in young unmarried females with common clinical symptoms of severe dysmenorrhea? And this is, I think, from Dr. Madhavi. She has sent this question probably. Dr. Atila, would you like to answer this?
Yes, please. If you can just repeat it.
So
what
it is the central junctional zone abnormality. The imaging patterns suggest progress to reflux menstruation with concomitant deep endometriosis.
Okay.
It progresses to intrinsic diffuse adenomyosis with anterior and posterior wall involvement. How do we confirm in young patients and follow-up cases of junction zone abnormality diagnosed in young patients with severe dysmenorrhea?
So again, the question is whether this person has active child wish or not. If she doesn't want to become pregnant, firstly, I would definitely go for an levonorgestrel containing IUD. In case of active child wish, I would recommend operative laparoscopy, removal of all visible endometriotic lesions, and I wouldn't touch the uterus, and I would refer the patient. It's really depending on tubal patency. If the EFI, the endometriosis fertility index is higher than 7, I would recommend a spontaneous pregnancy trial. So this is my approach. So I would be very, very conservative with advising surgery for adenomyosis in these patients.
Somebody has asked, can adenomyosis recur even after adenomyomectomy? How is add-back therapy given when on GnRH agonist?
Add back with GnRH agonist. So we have oral GnRH antagonist therapy available. It's not agonist, it's antagonist, and it's called relugolix. It's 40 milligrams in a tablet, and we have also 10 milligrams of estradiol and 2 milligrams of Dionages. This is available in Hungary, in Europe, and actually this is quite an effective drug. I have to tell you that I was surprised that the side effect profile is acceptable, and the bone mineral density is stable because of the add-back therapy. So yeah, we have data for 2 years follow-up, and so far the outcomes are very, very favorable.
That's nice.
Dr. Anita has a question about when should the woman go for pregnancy after an adenomyomectomy is done? How many months gap should be given before she gets pregnant?
I would say 6, but Vimi, what's the thing?
I advise 6. For myomectomy, I advise 4 months, and adenomyomectomy 6 months.
Dr. Biswajit Ghosh says has a doubt about a 35-year-old woman with adenomyosis who is treated medically and she's become pregnant with IVF, and she delivered by a cesarean section. And after 1 year, developed scar endometriosis. I think both adenomyosis and endometriosis. And the doubt here is there any medical treatment that can be recommended?
Maybe the best option for scar endometriosis is just a very simple excision. You know, this is not a high-risk surgery. So the best way to treat this, I think, would be the surgery.
Yeah.
And going back to the older question, they just asking about if adenomyosis can recur after adenomyoectomy, Dr. Rajiv.
Yes, yes, definitely. The problem is that we have shown you a new review and meta-analysis on recurrence and re-intervention after excisional therapy of adenomyosis, and also non-excisional therapy. And we see that there is a fairly high chance for recurrence. It's around 10% after non-excisional therapies like radiofrequency ablation or HIFU, and it's around 3% after excisional therapy. So I think it's fairly lower, the recurrence rate after excisional therapy. So this is definitely the advantage of surgical excision.
I have a question for you. Do you also use radiofrequency ablation and microwave ablation?
No, never.
Yeah.
I don't have what we do actually, we mean that in very desperate cases we do surgery. So after several unsuccessful IVF therapies with symptomatic patients, we do Osada procedure or wedge resection or just simple laparoscopic adenomyoectomy. But this is what we do. And I have to tell you that maybe in terms of symptoms, it really helps, but I'm not sure that regarding the treatment of fertility is really helpful. So this is, you know, it's a too mechanistic approach of this disease, because there's no cleavage plane in adenomyosis. I've seen your surgeries. You're a very skilled surgeon. Congratulations, very nice procedures. But you're just simply not able to see what is healthy and what's not. So you will end up with a deliberately incomplete surgery, which is okay. In adenomyosis, we can tell this to the patients. But if we do these surgeries with an aim to improve the fertility, I think, yeah, maybe it's not the best way to treat this disease. But for the symptoms, heavy menstrual bleeding or chronic pelvic pain, I think it makes sense. Regarding your question, radio frequency ablation, there is a nice paper from the Michel Muller's group in Bern, and I would like to visit them actually, because seemingly it's not a complex procedure, and if this really offers a lot of positive outcomes for the patients, maybe we can try. So at my department, we could buy an instrument and try to do.
So we have started doing microwave ablation, but not the radiofrequency one.
Okay.
So still we haven't bought the instrument, but we get it on lease whenever the patient demands it, like we have a procedure scheduled and patient does not want adenomyoectomy procedure and she wants something conservative. So we started doing microwave ablation. We need to follow them for a longer time and see the results.
Sure. I think at least for 24 months, the follow-up should be long enough to have any conclusions. But so far, what is your opinion? Is it helpful?
Yes, whatever patients we have done, I haven't followed them for 2 years, but 1 year follow-up is done. So there was a significant 60 to 70% reduction in the adenomyotic volume.
Oh, that's cool.
Fertility outcome, even I have not studied yet. So, but pain scores and the reduction in the size of the adenomyosis is huge.
It's very good.
I think
There is one more question. Diagnosed with adenomyosis and endometriosis. She's 37 years. Would like to be pregnant in future. No operation so far. Is it possible to heal adenomyosis and naturally without surgery?
Maybe it's possible, but I'm not aware of these treatments. We never know. Maybe there is some, like traditional Chinese or maybe Indian therapy. We Hungarians, we just drink a lot of wine. So this is our approach.
I think we have Dr. Sandesh here with us, and Dr. Sandesh does a lot of myomectomies. Dr. Sandesh, are you there?
Yes, sir, Dr. Sandesh. Hello.
Dr. Sandesh.
Yes.
Yeah, because we wanted to hear from you your experience in adenomyosis. I think he's traveling.
Yeah. Maybe it's cycling.
Maybe. And Dr. Harald had to leave for an emergency, and he apologized to all of us.
Hello. Sorry. I was actually traveling. Hello.
Yeah, Dr. Sandesh, we can hear you.
Yes. Yeah. What was the question? Sorry.
No, I was telling Attila that Dr. Sandesh has also huge volumes of adenomyomectomy. So we wanted your experience of adenomyomectomy surgeries.
Yes. Actually, we do have now lots of adolescent adenomyosis and also for fertility issues. So basically, we give medical line of treatment for everyone. Secondly, GnRH also is a very good method in our system to do before any surgery. And if the patients are not responding to the medical line of management and they have focal, adenomyosis, then we are very much in favor of performing the surgeries. Now, if we have the generalized adenomyosis, then in a very early stage, so again, they receive the medical and the GnRH injections if they respond very good, otherwise the surgeries. But if at all very large, very huge and generalized adenomyosis, we really don't depend much on the very radical surgeries. So that is our protocol. And basically, the question which was asked about adolescent girls with progressive disease where you have junctional zone, that is a very, very common occurrence nowadays. They have only junctional zone problem. I mean, the thickness increases and they have severe symptoms. So a lot of times on ultrasound, there is a chance to miss these patients, but they are in severe pain. So in those cases, I think if you happen to do the MRI, then you pick up these cases faster. Then rather, I think the lot of cases being missed on ultrasound, especially for only junctional zone abnormalities. That is a very huge chunk of patients reporting with severe dysmenorrhea.
Okay.
Yeah, that was the first spectrum I mentioned about because these patients go undiagnosed. And yes, LNG-IUS has worked very well for them. But there is also a subset where LNG-IUS is not working. So what is the solution for them?
Actually, LNG for the junctional zone really works well. But if at all it is not working, then there is no surgeries for junctional zone thickness. Okay. Because that would be very radical surgeries and actually too much of destructive surgeries. So basically, again, I think creating amenorrhea, GnRH should injectable, or actually we have to think, I think whether that has been discussed by Nuri madam about the abnormal myometrial contractions.
Yeah, I discussed about junctional zone abnormality, the details of that.
Okay. So I'm sorry, I was not present. Myometrial contractions also.
No, but then what is the solution for them? That is what is the question, because these patients do not respond to any of the medications.
Have you discussed that?
These are very small subset of these patients who do not respond to any of the medicines or LNG isotones. But then we can't do any surgery, we can't do anything. How to manage them? These are younger population, not even completed their family, desirous of pregnancy in future. What do we do with them?
No, that is a big dilemma actually, but we really have to understand whether are we missing something in these patients and labeling them as adenomyosis, but they are not responding to the regular management of adenomyosis.
Yes, this is also very important, but maybe in this subgroup of patients, we might advise the radiofrequency ablation.
Yeah, maybe that will work.
Would be an option. No more questions?
No, somebody said very informative and updating, and all 3 lectures were very good. And thank you so much for joining us, Attila. Thank you, Harald. He left after his lecture, but he had an emergency. And EFI thanks you and EEL as well for collaborating on this webinar. And we will do some more sessions on different topics.
Thank you very much for the opportunity. And I would also like to invite you for a collaboration, because I have the feeling that you may see a lot of patients. And as you know, we conduct a study on endometriosis. Actually, it's a data scientific study. We have to collect big data. We use an app, a Lucy app on mobile phones, and already we have gathered data from Northern Europe, like Denmark, Sweden, Scotland, UK, and Germany, Austria, Hungary, and France. But so far we have only 30,000 patients included in this study. This is the female study, which is a large multicentric study within Europe. But if you are interested, we want to assess the patients' complaints and patients' profiles in order to find out how can we maybe possibly use these huge data with machine learning and AI assessment to develop a new patient profile. So our idea would be to gather as much data as we can. And I have the feeling that you have like much more patients than we do.
Yeah, happy to collaborate. I am coming to World Endometriosis Conference. So I will meet you and we can take it forward.
We can see each other there.
Yes.
Okay, so we can talk.
Yes.
And thank you for the invitation, Vimi. So thank you.
Thank you. Thank you for joining us. Thank you, everyone. And more than 100 doctors joined us today. More wanted to join, but unfortunately, the limit for Zoom was only 100. So from next time, we will keep the more limit so more people can join us.
Okay, then.
Yeah. Thank you.
Bye-bye.